Well, kia ora koutou katoa. Welcome back to Manatu Hauora, no mai haere mai. Thanks for joining us again for our second briefing in the series on the vaccination program. With me today, I've got Dr Samantha Murton, who's the chair of the Royal New Zealand College of General Practitioners, and she's also a GP here in Wellington. So Sam, thanks for joining me today.
Yeah, no problem.
And we're looking forward to the kōrero with you. We've got about 45 minutes through to quarter two, and so we'll make our introductory comments reasonably brief to give as much time as possible for questions. Of course, those are often famous last words. First of all, though, just quickly on the usual numbers in terms of new COVID cases. So today, just the one new case that's in managed isolation in New Zealand, no new community cases. In terms of the Melbourne situation, we've not been notified about any new cases identified through the follow-up testing of close contacts in Melbourne. Their whole genome sequencing has confirmed the link back to the managed isolation facility in South Australia that the index case was at. And so that's encouraging in the sense that it's not from the community. We remain in close touch with our Melbourne colleagues, obviously. Similarly, no further developments from the Sydney cases last week, no further cases identified there in the community in Sydney. And as part of the follow-up from Melbourne, we've had two people here in New Zealand who have contacted Healthline because they were in places, one of the places of interest at the time of interest, and both those we've been in touch with from our national centre. They're casual contacts and they've been provided with advice as appropriate around testing. So I'm going to talk first a little bit about vaccine supply, role of general practice. I'll hand over to Dr Murton, and then we'll carry on. So as we talked about yesterday, with the Minister, the program is continuing to scale up in a, as I describe it, safe and measured way. And we're now averaging somewhere between sort of 12 to 16,000 doses being delivered every week across the country, every day across the country. And that's about the volume we will remain at until we go through to the end of June. And then, as you know, in July, we have those larger weekly drops. At the moment, the weekly amounts from Pfizer are between 50 and 70,000 a week. The supply so far has been uninterrupted. Pfizer has delivered to schedule, and so we've got a high level of confidence in their intention and ability to deliver once those bigger drops come online. But we do recognise, of course, that the international situation remains volatile, not just in terms of the pandemic in some countries, but of course, there are still some potential disruptions to supply lines. They are fragile, and supply chains are fragile in some parts of the globe, and we haven't had any difficulties to date. But obviously, there are some uncertainties still, and many of those we can manage, but some we can't. In the first instance, of course, and through to the end of June, while the supply is constrained to about that 1.1, 1.2 million doses, we've been guided by our sequencing framework. That changes once July comes around and there's more vaccine arriving. I think you've got a pack that's been handed out. If not, you will get it at the end. There's a graph in there that shows the sort of the balancing we are doing between the supply that's arriving between now and the end of June and the delivery. And so by the time we get to the end of June, the stocks in our freezers will be down pretty low. We're trying to make sure we're delivering as much as possible of that. And as I say, in anticipation of the bigger volumes arriving through July. Right from the start, we've had to pace ourselves through the roll-up. So the first big scale-up has been to this sort of around 12 to 16,000 a day. And then as we go through July, it will scale up. And just another thing to point out, July is school holidays month, and that means that not only are some staff taking holidays, but we do see in the case of testing that testing drops off during school holidays. So it will take through July, I would imagine, to scale up to that volume of around 50 to 70,000 vaccinations a day. We're actively managing supply and demand. As you would have seen yesterday, overall, we're about 107% of plan. So we're talking regularly with the DHBs around making sure that they're delivering to their plans, but also not getting too far ahead. And furthermore, we don't want to get to the end of June and find that we are behind on our equity targets. So we want to make sure we are delivering for those Māori and Pacifica communities right through, and so that we as we roll out into Group 3, a real focus on ensuring those communities can access the vaccine. I've talked about some uncertainties around supply chain and potentially manufacture. We haven't had any of those yet with Pfizer, but we do have contingencies around other alternative vaccines. The one that's furthest down the track with approval next is the Janssen one, and that is going through its process. The Medicines Independent Assessment Committee meets on the 18th of May to assess the evidence from Janssen around the Janssen vaccine. So we've got contingencies, but of course we have committed to the Pfizer-based program, and that's our full intent, is to stick with that through this year. So just a couple of other comments. First of all, as I've said in a number of times in the last week, vaccinating the population is the second most important thing New Zealand is doing this year. The most important thing is keeping the virus out of the country. And it may not be visible, but every day there is a huge effort going in to do that. And it's a great position to be in, vaccinating our population in an elimination type situation, and we have every intention of maintaining that. But that does require a lot of effort across government, the community, and the health system, and we mustn't forget that. So it continues to be a team effort here. So just before I hand over to Sam, I would like to just thank primary care for not only the work they've done as part of the response to date, but also the role they are already playing in the vaccination program. And general practice teams have already been involved in a range of places around the country and setting up some of those and delivering vaccine through some of those existing community hubs. There is a more practice-based model that's being trialled at the moment in a couple of locations around the country, with the intention that as we move into July and that next scale up, we will be able to include quite a number of general practices around. We're thinking initially around 30 to 40%, quite a proportion of practices will tend to be the larger ones. In that 800, we're working on around 800 venues where we will be able to logistically provide the vaccine to from July. So that will be a mix of those existing community hubs of different scale, some large scale events, one-off type events. It will include workplace-based vaccination. It will include mobile teams going out. Like, for example, at the moment, they're going out to aged residential care. And it will also include that primary care-based model, and particularly in general practice and in pharmacy. So at the moment, we've got around 50 community-based hubs already in play around the country. And once we get to July, a total of 800 sites. And initially, we're thinking around 30 to 40% of practices, with a view that that increases through the year. And Dr. Murton may well want to comment on that as we go through. And I guess just one other thing on that is, of course, as we move through, and our aspiration to ensure every eligible New Zealander has had the opportunity to be vaccinated this year, as we settle into a rhythm where it's doing follow-up of people who may be coming into the country or become eligible for the vaccine, for example, if it extends to another age group, then general practice and pharmacy will be playing the main role into the future, as they do now with our vaccination programs. And that would include if boosters are required in future. This is everyday business for general practice, and Dr. Murton will talk a little bit more about that. Finally, for people who are very keen to get their vaccination, rather than ringing your GP, just keep watching the information. And as we roll out into Group 3 and then 4, there will be good information about how you can book your vaccine and indeed where you can access it. So I'll hand over to you now. Thanks, Sam.
Thanks, Ashley. Yeah, so general practice, we surveyed the general practitioners to see how keen they were. Having done a workforce survey looking at the burnout, we're worried that there may be some concern about rolling out the COVID vaccine, as it was going to be Pfizer for the rest of the year, and to get it out to the whole community. General practice is essential to that. The survey showed that we had 60% of our members were really keen, and about 30% were a little bit unsure, but that was because they didn't have enough information. the biggest issue that they have is around staffing, and that was if whatever the funding model has, which we've got out now, which is great, then that was where it would go, is into getting extra staff in to be able to do the vaccination, and especially around administration of it, because it is a little bit more administrative heavy than the other vaccines have been. Vaccination is our gig. It's what we do every day. Every practice across the country is doing flu vaccination at the moment and busily filling up their waiting rooms and stuff with those who are eligible for flu vaccine and request it, so that then when they become through eligible for COVID vaccine, then they can have that 2-week window. So we're all under the pump, making sure that everyone's getting their flu vaccine. I think the other thing is that most of us were keen to be involved with at least a proportion of our population. So 50% of the practices who responded said that they would be keen to do the whole population for their practice that were eligible. Another 40% said that they could do somewhere between the eligible high needs population or at least half of their population in their practice. So there's a lot of capacity and capability and a lot of keenness to be involved, because from our perspective, we want to make sure that our patients get what they need, and also be involved in that process, because as COVID swabbing has gone on over this last year, I think when it first started, we were all like, I can remember sitting outside my practice with a lineup of people poking swabs down their noses going, am I going to be doing this forever? And now it is just run of the mill. And so this will become part of our usual business. It's just a matter of working out how we start to factor it in and then move forward, keeping it as part of our usual. So that's where our sector is at, and very keen to be involved. But it will be how does it pan out over this next year and the next few months is what we need to look for.
Yeah, good. Thanks, Sam. Happy to take questions.
How many GPs will you want to join the vaccine rollout, and when would you like to see that be done by?
Well, from our perspective, over time, I would expect, and we would want to be able to enable every general practice to be part of the program. Logistically, the constraint is, and again, just to point out, we're actually in a different position now from what we were 3 months ago. We didn't even think we could involve a largish number of general practices. We thought it would be much more confined to hubs because of the logistics of this vaccine. We now feel from July, we're planning for 800 different sites, and that has allowed us to now involve what I think will be around at least a third of practices, and also maybe a quarter of pharmacies as well from July. But over time, our aspiration would be to, again, further strengthen the logistics processes and our ability to get the vaccine out, and we will learn as we go along how practices can do that.
Yeah, from a practice point of view, distribution is a real issue. So if we are told that we can start vaccinating and then we don't get vaccine coming, it is very disruptive. So if you look at, say, an area like where I am, there's 3 practices that are around that area, and if one of them says, well, look, we'll do for your group of practices, then that would be an easy way of getting the 30% involved and not having everyone doing it all at once and not getting the supply coming through. So it's much better that we slowly increase over time than sort of have everyone going all at once and then start to get to struggle. Yeah.
Those GPs that would they need to undergo online and practical training to handle the Pfizer vaccine?
Yeah, so there is a training program for the Pfizer vaccine. We're doing vaccinations all the time anyway. So for those who are designated vaccinators, like nursing staff in general practice or for GPs, we know how to do the vaccination. We know how to talk about risks and those sorts of things. But this is a particularly tricky vaccination in that you have 6 vaccines per vial, whereas normally we just get a syringe with a vaccine in it. So there's a few nuances, and there are training programs that we can do that's available to us now. And it's easily accessible for anyone who wants to join.
Having 6 vaccines in one vial, how will you manage the supply and minimise wastage?
From a general practice point of view, what we're looking at is if we're getting, the strategy is that you can deliver at least 30. So it always comes in a box of 30. And so you have to be able to get rid of that 30 in a timely fashion. So we are looking at practices being able to step up to that capability, and then and there'll be systems that they put in place for that. And many of us have gone through some of the vaccination centres that are running already, so that we know how it works. They've looked at the logistics. We had a open day at the local one, so that we could all go down and see how it all worked. And from a college perspective, we've been out to Trentham to see what their process is like as well. So getting all those systems set up will be part of the way that we roll it out.
Yes, so there will be this minimum of 30 a day. That's the smallest sort of box we can send out. But the other thing is we're doing, in every DHB, there will be a local logistics lead. And so rather than it all just being done, it actually needs human interaction as well. And so that person will be able to move vaccine around between different locations to make sure that once it's, recalling that once it's sort of defrosted, there's a 4 to 5 day window it needs to be used. And so far we're doing very well. WHO says do your planning on at least 10% wastage, and we're down around 3% at the moment. So we'd like to maintain that.
Yeah, and seeing those systems, the way it works, the wastages can be mitigated really easily.
What do you mean by sort of a timely fashion? What does that sort of entail?
For getting the vaccine out. Yeah, so that's the whole process of when it arrives, it's got 5 days to be able to be used. When you've reconstituted the vaccine, it has to, if it goes out of the fridge, it has to be made up into syringes within 2 hours. Once that's made up into a syringe, it's got 6 hours to be stuck into someone's arm. So that's the timeliness of it all. Yeah.
So you've got to have a good process to make sure you've got all 3 of those things.
Yeah.
A third of that sites will be GPs, or a third of GPs will be
about a third of GP sites. So we've had a look at what the mix is likely to be to ensure that we can hit those numbers of 50 to 70,000 a day at the peak. And our view is that it will be around 30 to 40% of general practices, at least at the start, and then and maybe around a quarter of pharmacies as part of the mix, with the view to then we can start to extend out further from there.
Have you predicted how much more will need to be done a week if the 12 to 15 ones are approved?
Well, that's around another 250,000 people. And there are 2 elements to that. One is we would like, as soon as that is approved, we've got enough vaccine to include that group. And so we would like to create the opportunity for those, that age group to be vaccinated at either community-based centres or through general practice. But we're also starting to do some work on possibly a school-based program for end of term 3 into term 4 for that group specifically. And the planning for that's just getting underway.
Would you still have the anticipation that even if 12 to 15 is also able to access the vaccine, that anyone who wanted to be vaccinated by the end of the year could be? Or does that blow out the deadline a little bit?
We would be wanting to include the 12 to 15-year-olds in that group, because it just helps with our overall population coverage and therefore sort of population protection. And the good thing about that 12 to 15 then is, and this is the value of school-based, is that's your secondary school students basically, for the most part,
And what's the role of pharmacies in the rollout in that sort of 800 sites? Do you expect pharmacies to be delivering vaccines at all, or just a small number? Or?
Yeah, so I think there's about 1,000 pharmacies in the country, and our modelling is on about a quarter of them being involved. So not all pharmacies vaccinate already. At the moment, some pharmacy teams are already involved in staffing those community hubs, and our sense is that probably about a quarter of pharmacies will be involved, at least from July onwards. Yeah.
Who's authorised to give the vaccines? Is it just doctors, nurses and pharmacists? Are other health professionals able to do it?
It's a very wide group now, so we've extended that to pretty much every registered health professional. So those who are covered by the Health Practitioners Competence Assurance Act are able to do that. We are also just in the process too of going through the process of changing the regulation to allow our non-regulated, what we call kaiawhina workforce, to become vaccination assistants. So under supervision of a nurse or a doctor, they would also be able to vaccinate. So we've got a pool now of over 4,500 vaccinators already trained, and we're aiming to have at least 6,000 by the end of June. Yeah.
That 30 to 40% of GP clinics, what's the major constraint around some clinics that feel they won't be able to get involved? Would it be, is it mostly staffing, or is a fair bit of it physical, that the clinic's just not big enough or doesn't have the appropriate sort of
There's a
space?
bit of a mixture. I think staffing was one of the main issues. Was I don't have enough staff, or and some of them are maybe sort of rural areas where it's actually difficult to get vaccine to, but then again, it's difficult for travel. So how, if you are struggling with staffing, can we look at logistics of getting a vaccine program to that particular group? And that's where the mobile stuff is really essential. There are other practices that are just really small, and so we've been having a conversation with another smaller practice near us about what they might do and how we could roll that out for them as well. So it is a real variety of reasons why people won't have the capacity really to do it, not the capability. Yeah.
You said by the end of June, stock is going to be quite low on the Pfizer vaccine. What work is being done to mitigate the impact of the Pfizer vaccine rollout?
Well, I think the key thing here is we've got confidence in our supply through to June, and so we're phasing the program to meet the supply, and we will see the several 100,000 doses that are now in our freezers will start to go down, and we're just making sure we match demand and supply. We're in discussion with Pfizer around getting certainty around the delivery from July onwards. We're confident they will meet what they say they will, but it's just then making sure we can get those first drops in the first couple of weeks of July. And the key point here is, and I made it yesterday, the plan is to vaccinate all eligible New Zealanders before the end of this calendar year. And for my part, I'm in group 4. I don't feel I need to rock up on the 1st of July. The important thing is that people are vaccinated, not necessarily when they're vaccinated. So saying our sequencing framework has had clear science behind it to protect those who are most at risk, our border workforce, and then those who, if they got COVID-19, would have the worst outcomes from terms of morbidity and deaths. But also, of course, we've had our health workforce right at the forefront of that too. So the key thing here is there is enough vaccine coming this year to vaccinate the whole population, including that 12 to 15-year age group. Yeah.
New Zealand's being accused of criticised for vaccine nationalism in the World Health Organization independent panel report. Do you think that's an accurate characterisation or a fair one?
I think what the report did do was it called out this issue of a range of countries that, as part of their sort of getting ready for vaccination, didn't just put all their eggs in one basket. So, and New Zealand was one of those countries. So we have got those advanced purchase agreements in place with a range of manufacturers and manufacturers who use different technologies. That was, I think, a really judicious approach to take. We now have got a Pfizer-based program, and so our conversations now and our discussions with those manufacturers now are the ways that we can both cover off any risk in our program, but also make that any vaccine we don't need available. And you'll have seen already New Zealand's donated its allocation through the COVAX facility, which we also was another sort of basket of eggs we had. We've already donated our first allocation of AstraZeneca vaccine back to that facility to be distributed wherever. We've said we would like that to go to the Pacific if possible. We know that several Pacific countries have already started AstraZeneca-based programs, so that gives them further access to more vaccine. And I think you will see, and we're providing advice to the government about how we can free up and donate other vaccine that we have got purchase agreements in place for, which requires us to follow through on those. So we will do that, but then make that vaccine available to low-income countries. None of us is safe until all of us are safe in this.
Do you agree with Helen Clark's position that we should be giving our surplus vaccine to poorer countries? I don't think the panel was criticising countries for being prepared, but what the panel is saying now is the time, rather than still just hoarding the vaccine, is to start looking to how that vaccine can be freed up. And actually, we've seen that over the last, even just the last few weeks, to respond to the situation in India. The US has been particularly active in making available vaccine to support India with its program.
The Pfizer vaccine is expected to be on first flight to the Cook Islands. Is that a donation from New Zealand to the Cooks?
Not so much a donation, it's part of our plan originally. So with all the vaccine manufacturers, we had the intention right from the start to be able to purchase enough vaccine, not just for New Zealand, but for 6 Polynesian countries, and including the 3 realm countries. And so that was part of our planning. So that allocation is indeed part of our Pfizer allocation through our advanced purchase agreement, somewhere around 30,000, just over 30,000 doses.
When will the vaccines start rolling out to Niue and Tokala?
Our planning's going on with that, but that's obviously the decision around that lies with those countries, and we will be putting out some information about that soon.
Just on an international comparison, New Zealand's vaccination rates are just really low right now amongst developing nations, and even below a lot of, at the bottom of the OECD and below like developing nations like India and Brazil. Other places that are in that same position, Japan and South Korea, are just experiencing some pretty big outbreaks right now. Do you worry that New Zealand could be in that same position because the vaccination rates are low?
I don't worry about that, and that goes to my comment earlier about our paramount focus and task for this year is maintaining our elimination status, really. And this is the approach Australia has taken, as have a number of other jurisdictions. This is a challenging and unpredictable virus. We've seen even just in the last few days, Taiwan, which is held up as as one of the gold standard countries for its approach, has got some community cases, including cases they're not sure where they've come from. So it really is a virus that keeps us on our toes. If I think about Taiwan as a jurisdiction, Australia, South Korea, Vietnam, Japan's another one, countries that have tended to do pretty well in terms of keeping the virus out. We are very much on a par with our vaccination rates so far.
They're all the lowest in the world, those ones that you just mentioned.
Well, Australia's in a similar position to us. I think that's a good comparison. And we are, just to go back to my comment earlier on, rolling out the program in a safe and measured way. Our intention is that every eligible person can be vaccinated this year while maintaining our elimination approach. And I think there's no doubt in my mind that the best context you want to be vaccinating your population in is a context where you haven't got the virus in the country. And I'm sure my health colleagues would, frontline colleagues would agree with that.
For general practice, we're doing both. We're doing swabbing all the time anyway still, and keeping an eye on anyone who's got any respiratory illness, and then thinking about the vaccine. And we can't vaccinate more than we've got vaccine for. So we just have to run with what we can do and keep it at the highest capacity we possibly can with the volume of vaccine that we've got. And then as it goes on, just make sure that we are stepping up every step as we go. And that will mean that we get a large number of practices. 300 practices is actually a third, is what we're talking about, and that's across the country. And getting them all up to speed as soon as we need them to be up to speed is really important. And then making sure that they are talking with all their other local practices, and then rolling it out that way. So in every jurisdiction, I think we've seen that once you've got the volume in the community practices going, then that makes it ramp up really fast. But we need the vaccine to do that.
And they're just sort of like looking forward to next year with the elimination strategy. Do you let that go? I mean, the sort of zero tolerance strategy, once everybody's vaccinated who's going to get vaccinated, do you just have to let that go?
Look, COVID's always an evolving situation, and there's a lot that we can't anticipate, but I'll point to the PM speech later today, which I think will start to lay out the government's thinking around what the future looks like. We heard the Australian government in the delivery of its budget talk about, be prepared for mid-22 before the borders really start to open up. Our way into this so far, and it's proving manageable, is to open up quarantine-free travel arrangements first with Australia, the Cooks soon. But even that requires a lot of work, both to prepare for it, and then every time there's a case, it's almost like having a case onshore here. So every country is feeling its way. But I would just go back to your earlier question, quite clearly, and I think New Zealanders understand this, New Zealand's not in the same situation as Brazil, India, UK, USA, countries that have had major outbreaks, and some of them continue to, and we've avoided that with very deliberate action, and we're not going to drop the ball on that now.
If there was an outbreak, hypothetically, how would that affect the vaccine rollout? Would it affect how you plan to roll out the vaccine?
Yeah, we have done some planning around different scenarios, and our view would be even if a part or all of New Zealand was in alert level 3, that we would still be able to continue vaccinating, because you'll remember when we get community outbreaks, that's when we need and want people to get tested, and so we're able to manage testing in that situation, and we believe we could do that with vaccination as well. The only difference might be is if we had an isolated outbreak in a community, we would use we might use the vaccine to do a more sort of a blitz of vaccination in that community to help protect people, and then we would probably bring in people from other parts of the country to help support that initiative.
So you believe you could keep up vaccination rates the same predicted levels?
Well, that would be our aim. I'm sure it would have to scale back, in part because it takes a lot of effort on the part of DHBs, the health workforce and the ministry, I dare say, and the whole system to manage an outbreak when that happens. Even if it's just a few cases, it's a lot of work. And so that would, I imagine, have some impact on the vaccination program. But our intent is to keep vaccinating through any community outbreak.
Just back on the World Health Organization report, it found a lack of preparedness, slowness to act, and an absence of global leadership. What did you make of the report, and did you or did the ministry and the government find, and did that kind of lack of global leadership really affect how we responded to COVID-19?
Well, I dare say, and if I reflect back just over a year, and some of you were in the room at some of those early briefings, actually, we were looking very intensively at the advice and information that WHO was providing at that time, and that formed a important input into the decisions we took here. I think that there are two things I think that are important from the report. The first is the emphasis is more on how countries did or didn't respond to that advice and the time that was lost in responding quickly, because ultimately WHO can give the best advice in the world, but it's incumbent on countries to take on board that advice and then to act on it, act decisively on it. The second thing is, and this is, I think, a really key conclusion of the report, and having been briefed in the briefing from the chairs last week, the co-chairs, WHO needs to be empowered by the member states and funded by member states to be able to deliver better on that global leadership role. And it needs better, and we need, as a global community, probably better legal frameworks to enable a much more rapid global response. So the important thing here now is what happens in 2 weeks' time when that report is discussed at the World Health Assembly, and what countries and what member states commit to doing in response to those recommendations. And New Zealand will be responding positively and trying to act with a group of countries, I think, to really lead strengthening of our global systems. Yep.
Some people would say New Zealand's pandemic response was completely opposite to what the World Health Organization advised. Why did we kind of take a completely different approach to the WHO?
Well, we took on board the advice from WHO at the time. However, it was also different from our own pandemic influenza plan. We were responding to what we were seeing and the evidence that was emerging at the time. And I think this is one of the major findings of that report and the panel is there needs to be excellent information sharing, and countries need to have in place good rapid decision-making processes. And this goes to the preparation of individual countries. You can be extremely well prepared and have well-resourced public health infrastructure, but if you haven't got really good rapid decision-making mechanisms in place, which we did have and do have in New Zealand, then your preparation can be all for naught. So I'm pretty happy with the extent to which we embraced and utilised WHO advice, but weren't constrained by that.
The recommendations of the independent panel report was that, in the short term, countries should appoint national pandemic coordinators who have sort of this all-government role. Do you see a role for that in New Zealand, as you or someone else being the sort of pandemic czar whose focus is just COVID?
Well, the reflection I would make is, and we've seen this in New Zealand, is that the response is actually not the purview even just of the Ministry of Health or of a single person, but it is truly, even not just an all of government, it's an all of societal one. And so I think the key thing from my perspective is having good leadership and good leadership structures and good decision-making structures, because you need to involve a lot of people in the development of advice and then in the actual decision making. And so, yes, having a sort of a czar or a person who's just thinking about it may well be useful, but it's having all those key pillars of a response in place and making sure that the whole system really is trained and has got the capability and capacity, including out onto the front line.
Yeah, because when we were, for us in general practice, we had 2 of us were involved in the stand-ups every morning throughout February, and it wasn't until we got to that point in March where it was just going off in Italy. And we actually met the day before the Prime Minister talked and with all our GP leaders and said, this is going to go off unless we do something. And so it was a whole of sector approach and meant that we were all involved and we're all on the same page saying that this is for the country, we need to be able to do this. And so GP flipping to telemedicine overnight was absolutely huge, but it was the thing that had to happen. And that's the sort of like, we had the backing of leadership from within the ministry and elsewhere as well, but it was still something that as the leaders you sort of go like, ugh, do we need to do this? Every decision that was being made globally at that time felt like it was 2 weeks late, and we were making decisions that felt like they were 2 weeks early, but actually that's what made the difference.
Much has been made of the fact that the WHO has limited power, money and resources. Is there anything particularly you would like to see in terms of a more beefed up kind of WHO?
Yeah, there are those 2 key things, and I've been in and around the WHO system probably for about 15 years now, and the thing about the WHO and other multilateral institutions is they are only as strong and as enabled as their members will allow them to be. So this is a really important juncture where the member states of the WHO need to agree on and decide what power they will give to the organisation, but how they will underpin that with the requisite funding and the requisite sort of agreed treaty mechanisms. And I think one of the recommendations of the panel is to look hard at whether there needs to be a stronger treaty that underpins international action in response to pandemics, similar to, we have a global treaty around tobacco control, and so a framework convention it's called, so that there's that idea is put out there, and it'll be up to member states to make a decision about that, but that will be the discussion in a couple of weeks' time. Yep.
When would you expect the 12 to 15-year-olds might be approved for the Pfizer vaccine in New Zealand?
So the evidence is coming to MedSafe at the end of this month, and I would imagine within the few weeks after that, they would have had an opportunity to look at it all. It will be additional to the existing evidence, so I don't think that will take long, and then the independent committee will meet and make its assessment. So it's hard to put a time frame on it, but I would think that pretty much in concert with the wider rollout from July, we would have that approval, and then once it's been through an independent process, recalling that in the US at the moment, it's only an emergency use approval. It hasn't been through the full approval process. So then we would be able to think about how we can include that group in the wider rollout as well.
And what about the AstraZeneca approval? Is that
Yeah, it's still progressing quite slowly, and that's around the provision of data and responses to questions that MedSafe is putting back to AstraZeneca. So it's happening in the background, but it's a little further down the track.
The work that's being done on getting that vaccine out in schools, is that sort of being vaguely, what you put together there is vaguely, I think, 2 or 3 months until if it's approved, when it gets approved. Is the work in schools sort of wanting to act in concert with around when that might be approved, and also, I mean, on balance of probabilities, if the school strategy looks good, is it most likely that most 12 to 15-year-olds will actually be vaccinated at school? Is that a desirable goal?
So our existing school-based programs, which is in particular HPV, is largely school-based, but some people opt to have it done at their general practice. So a reasonable amount of HPV vaccination.
So HPV and tetanus at 11 all happens in the schools mainly, and in general practice we might see them occasionally. So there's a really good system. I imagine we'd have to bust up that system to be a bit bigger volume of staff to be able to make it work, but it would be doable.
So I think you'll see a mix. I imagine there will be many whānau that as soon as it's possible to have their 12 to 15-year-olds vaccinated, they will do that, and they will do that through the community-based programs or through general practice. And it may well be that a school-based program is not needed, but we're just starting to think about that, and that would obviously require discussion with close discussion with our education colleagues, because it's going into term 4. It's a term 4 is when, of course, the more senior students have got exams and so on and so forth. So it would need to be well planned and make sure it's not disrupting other activities.
Do you think our rollout has to be finished before we can even consider opening the borders beyond bubble?
Two things about that. Vaccination will be a really significant part of us being able to keep New Zealanders safe and protected, no doubt about that. However, it will still only be a part of that. One of the observations, I was talking to Rob Fife earlier in the week, and he said he'd been to Queensland and noticed a difference in the sort of the baseline level of expectations there, even with no cases in the community. So wider use of masks than here. And also, for example, in hospitality settings, still people can't serve themselves and so on. So it may well be, well, I strongly believe that even alongside vaccination, we may well need to lift our baseline level of what you might call public health protective behaviours as part of our move to open up to even a wider group of sort of what you might call low risk countries, let alone beyond that. So what we do here, and I think we're very fortunate as we go, might need to go up a level, but once we're in alert level 2, life is pretty much back to normal. Aside from those of us who occasionally or more occasionally use public transport, we have to use a mask. It may well be that we need to be more at a 2.5 level as our baseline alongside vaccination as part of the protections we need in place routinely to be able to open the border. And we're putting some thinking into that.
But that would suggest that we would want the vaccine to be rolled out before we would consider opening the border.
Oh, there's no doubt that, and that's why the intention is before the end of this year. There's no doubt that having as much of the population vaccinated as possible is key to us being able to open the border.
We would really consider doing that without having as many people vaccinated as possible.
I think the Prime Minister will have things to say about this this
afternoon.
afternoon. Oh, right. Well, I definitely won't comment further because I don't want to say anything that might. Yes, yeah. Yeah, I mean, it's an even important part of thinking about extending quarantine-free travel arrangements, because in addition to vaccination rates here, we're also interested in what are the vaccination rates in the countries we might be thinking about extending that out to, and also what's the situation on the ground there. A vaccinated person, an unvaccinated person from a country that's got no or little community transmission is at a lower risk of importing the infection than having someone travel here who might be fully vaccinated but coming from a country where there's a high level of community transmission. All those things have to be taken into account.
Yeah. It seems like on the results so far about vaccinated people, the chances of them transmitting is very low, even if they are coming from a high risk country.
It is, but the likelihood of them being infected is higher. If there's, even with a very highly effective vaccine like the Pfizer one, 95% of people, well, that still means, say, for every 1,000 people traveling from that country who might be fully vaccinated, there'll be 50 of that 1,000 people could potentially have been exposed. If they've been exposed, might have got infected. So there will be more than just consideration of an individual's vaccination status and thinking about those future travel arrangements.
And then when we get to that point, then we won't really have our
It's last questions.
When we, if and when we get to that point, then we won't be pursuing full-on elimination.
We've just got to. I think there's still work to do and thinking to be done about what that would be, what the situation will be. And one of the good things here is we have to date, and we'll continue to work really closely with our Australian colleagues, because they're also thinking about exactly these same issues. And particularly because we've got quarantine-free travel in place, we would be wanting to be very lined up in the approach that we were taking. There's no doubt that in a future, and this is a 3 to 5 year, I think, horizon we're talking about, that as COVID-19, as vaccination rates increase around the world and COVID-19 moves to being a more endemic disease rather than an epidemic or a pandemic, that it will be in communities, it will be in countries routinely around the world. And that means that here in New Zealand and in other countries, they will need really good public health systems in place for identification, contact tracing and follow-up. So
Yeah.
that's why we're continuing to strengthen those and
Yeah.
testing.
Yeah. So from a general practice point of view, if there's COVID, if we're all vaccinated and COVID still comes in occasionally, we need to be picking it up and making sure that we are alert all the time so that it doesn't spread around the community. It doesn't jeopardise our health system in some way, or we've got people who've got COVID who are ending up in hospital without knowing about it. So it's all that sort of stuff that we need to have discussions with to make sure that we've got a strategy for the occasional that could cause havoc. Yeah.
The trajectory, I guess, of the rollout in terms of, allowing our vaccine stocks to build up to sort of 450,000 and now steadily using them up more and more, was designed so that we don't have a phase where we have to scale down the rollout or sort of a pause. But yesterday, Minister Hipkins sort of alluded that that might still happen, and the PM as well said today that that's something that we should be prepared to happen, and it will.
Yeah.
But have you seen something? Is there some reason to believe that that we are more likely to hit one of those stumbling blocks now than you had thought sort of a month or two ago when first sort of preparing this trajectory?
Well, the good thing is our DHBs are not just achieving, but overall slightly exceeding the targets they had set themselves. And those targets were based on our indication to them of the sort of volumes we would expect them to do commensurate with the supply. I guess that what the PM and the Minister are saying, and I agree, is we would rather that if we had to just slow things down for a week or two, that we were doing that rather than sitting with vaccine in the freezer and waiting, because actually we want the vaccine in people's arms. That's where it's most useful. And so the team's working very closely with the District Health Board's daily discussions, really, just to get the balance right. So our hope is we get through, supply and demand match really well, but we would rather be in a position where if we had to slow down things for a week or two, we'd rather do that than having vaccines sitting in the freezer.
And when you look at those DHB targets, the point has been made that Northland, even if it's not hitting a certain percent of its target itself is to distribute 29 doses for every 100 people in Northland. What do you make of the DHBs and less ambitious targets? Taranaki DHB instead of targets vaccinating, or to administer 10 doses for every 100 people compared to, say, West Coast, which is 43 doses per 100 people. Those discrepancies there, it's going to be harder for them to catch up later on.
Well, each DHB has produced an initial plan through to the end of June based on what they felt they could do to scale up, with consideration of workforce and other things. But they also know that by the end of the year, they'll have needed to be able to vaccinate their whole population. So at the moment, they are working on and providing to us in the next week or two their plans for the July to the end of the year period. Some DHBs will be ahead of others in terms of proportion of their population, but they're best placed to know what's their capacity and capability to deliver. And again, they'll be now thinking about how they bring general practice, pharmacy on board, their use of other, sort of large-scale events and so on. So final questions, if there are.
I wanted to ask a general question about managing the flow of people. It's starting to seem, nearly impossible to manage. Right now we're going at like 12 to 16,000 a day. We have stories everywhere of people showing up and they can't get a vaccine even though they have a booking, and other people waiting for hours and hours, and other people can just walk in and get a jab. But clearly we need to try and get people to line up in sort of volumes that match what we have in the sort of places where we have it, and all those problems are just going to be exacerbated when we're trying to do 70,000 a week across 800 sites.
The 70,000 a week is probably, it's if it was in general practice, that's 70 per practice a day. And we see probably 40 people a day anyway, and this will be on top of it. But I think the other thing to think about is that if you've got a few number of sites with a big volume, then that's harder to manage than having lots and lots of sites with a smaller volume. And so once we distribute it further, having the smaller volumes coming through will be much more manageable. And there may be queues, but they won't be for miles. Yeah.
And just to put it in context, of course there will always be stories of people who've had to wait, or of some queues, or of someone who's missed out. But the vast majority of people who book in for their vaccination are getting vaccinated, around 16,000 of them a day at the moment. That's great. There will be good planning in place, and the national booking system will really assist with this, and it's already being trialled this week in Auckland. I think any system, it's a bit like going to a sports match, isn't it? Some people pre-book and they book their tickets, and some people just turn up on the night. And if you've turned up on the night at a Hurricanes game where the weather's fine, you sometimes have to queue to buy your ticket, and that's a little bit the case here. We're definitely keen to make sure the system works for everybody, but the key point is everyone will have access to a vaccination.
These people, when they go through the booking system, then they won't contact their own GP. Obviously, not every GP will be involved.
Yeah, that's something we're working with general practice.
It'll be a mixed model probably. There'll be the national booking system, but then also there'll be systems once you've got some practices that are involved, they'll be booking through their own practices in their own booking systems.
Yep. And the good thing is with a single underlying COVID immunisation register, the information is shared right across the system about whether someone has or hasn't been vaccinated, both their first and second dose. Okay, thanks very much. Really appreciate it.